range, that's when I kind of start to really pay attention. And now keep in mind too that the actual blood pressure, a lot of it is relative to what your normal blood pressure is. And so, for example, where I used to work in Detroit, a lot of people at baseline probably had a blood pressure of 180 over 120, and that was just their normal blood pressure. In other settings, if Matt is a very chill dude, his normal blood pressure is 110 over 70. He's a very healthy guy. If he got up to 160 over 100, that could turn into a hypertensive emergency for him. So it's all kind of relative, but roughly in the 180 to 200 range, over 100 to 120 range is when you should start thinking about, is this a hypertensive emergency? And then the second part of that, end organ damage. And what do we mean by that? And that can be a lot of different things. You can see it in the form of papilledema or optic nerve swelling that you see on an ultrasound. Any focal neurologic deficits have to catch your eye. Encephalopathy, such as altered mental status or seizures, are going to be end organ damage. Heart problems like acute coronary syndrome, some would even say just the existence of chest pain makes it a suggestion of end organ damage. Cardiogenic pulmonary edema from acute heart failure, mitral regurg, hepatojugular reflux, elevated JVP, and even like decreased urine output or hematuria in the acute setting if your kidneys are not handling this elevated blood pressure well. So when we have patients coming in with this elevated blood pressure, you want to make sure that you're doing a very thorough exam. You want to get a good mental status exam, very full neurologic exam. You want to be I recommend doing a bedside cardiac ultrasound. Listen to their lungs, look at their lungs with an ultrasound, make sure you're checking peripheral pulses. So, want to make sure you're doing a full neurologic exam and a full cardiovascular exam, cardiopulmonary exam. And if they're going to be there for a little bit, make sure you're checking your urine and looking at their urine output if you're suspecting that that's something that's going on. So a patient has come in, and we're just going to kind of move right into how do we go about managing a hypertensive emergency? We've identified that they have high blood pressure. And so this is kind of like a flow chart that I've made for you because it's really pretty straightforward hypertensive emergency. First of all, do they have an elevated blood pressure? If the answer is yes, do they have end organ damage? If the answer is yes, then is there an organ-specific process going on? And we're going to talk a little bit later about these organ-specific processes. Is there some particular etiology that's driving this elevated blood pressure, or is it just a general acute hypertension with end organ damage? And so if there's no organ-specific process, we're going to just apply general principles, which we're going to talk about here. And they're relatively straightforward. It's not that complicated. And so the guidelines, we're looking at recent guidelines from the 2020 International Society of Hypertension guidelines. And then also the ACC, the American Cardiology, College of Cardiology, and the American Heart Association, along with, it looks like 20 other organizations came up with clinical practice guidelines for hypertension back from 2017. So the general principles are really quite straightforward. They recommend, if you have hypertensive emergency, decreasing the blood pressure by 25% within the first hour, and then shoot for a goal of in the 160 to 100 range in the next 2 to 6 hours. So pretty straightforward. So I think we're all fairly familiar with this like initial 25% increase. And when we're looking at those numbers, sometimes there is confusion or questions. Are we basing this just on the systolic blood pressure, or should we use the mean arterial pressure? So is the mean arterial pressure a concept that I know that some people are very familiar with? Is that a concept that everybody is familiar with? And do your machines give you, when you have people on an automatic blood pressure cuff in the department, is it providing you a mean arterial pressure, or is that something you guys are needing to calculate? And this is a question for those of you at UMC. And I think at UMC, you probably get your MAPs calculated from your machines.
Sometimes we use catheter to measure means artery pressure, but most of case we don't use it. Just only non-invasive blood pressure. Yeah,
right.
But we use mean arterial pressure.
Okay. And yeah. Dai or somebody at Chorai, are you typically looking at strictly systolic blood pressure, or are you calculating the MAP, or do you have a machine that calculates the MAP for you?
Yeah, as Jerry, we always use the systolic blood pressure because I think maybe it's more convenient. And with the mean artery pressure, we don't always use it.
Yeah. And, you know, it's interesting because I was kind of reading into this as we spoke, and, you know, it sounds like we're all pretty familiar with, you know, the, you know, systolic pressure, diastolic pressure, and then the mean arterial pressure kind of showing up here in the middle. And that's usually calculated for us. You can do the calculation yourself. But like you said, it's more convenient to use the systolic blood pressure. And so I think it is more common that we use the systolic blood pressure. If you have access to a MAP, the mean arterial pressure, it's actually a better measure. And there's a few reasons why that I just figured I would bring up. The first is the risk of injury from the hypertension is likely also, there's probably a significant contribution from the diastolic blood pressure. And so the MAP better calculates and takes into account the elevated diastolic rather than simply the systolic. The second is it's actually easier to target a single number. Like we just said in that prior guideline, you know, you want to get down to 160 over 100. But what if you get down to 170 over 80? Then it's like, well, one of the numbers is low enough and one of the numbers is too high. And so the MAP sometimes gives a more clear target for, because it's a single number for your nursing staff. And then I thought this was interesting, and I didn't know this until I made this paper or made this talk, but the automated cuff, it actually only so the computer is actually only measuring the mean arterial pressure, and then it's estimating the systolic and the diastolic from there. We always get our first blood pressure manually, where the nurses will do it or the techs will do it manually. But after that, we use the cuff. And so it's kind of interesting to know that those numbers are actually simply estimations based on kind of a computer algorithm. But so overall, the MAP is better, but I think it's much more common to simply use the systolic blood pressure. That's actually what we use at my hospital is systolic blood pressure. Matt and Shakira at your institutions, if you put someone on like nicardipine, are you asking the nurses to look at the MAP or at the systolic blood pressure?
Hey, Ryan, I'll jump in here because we literally just talked about this the other day. And the answer is, I don't think anyone has come up with something uniform. And so people are doing it differently. But yeah. I think practically the mean arterial pressure is easier. And so I know that I was taught to use that, but I do think actually a lot of my colleagues actually just use systolic blood pressure.
Matt, what are they doing at Utah? You're muted.
I'm sorry, typically systolic, Ryan, but it's just, I think, a cultural practice here at the University of Utah rather than dogma. And I actually think there's a lot of argument to be made for using mean arterial pressure for everything that you've said. So this is a practice-changing lecture for me.
Yeah. Awesome. Could sneak in a few pearls there. All right. And so whether we use the systolic or mean arterial pressure, the next question is what medicines should we be using? And that's actually a huge in-depth lecture on its own. And we're not going to deep dive too much into that, but I do want to kind of cover some of the common medications. This was also hard because this is one of those things where I don't know exactly what you have available to you in Vietnam. So either anybody from Cho Rai or from UMC, what medicines typically do you have available to you to manage hypertensive emergencies?
Yes. Doctor, we will talk some medicine we usually use when we control the blood pressure. Dr. Wee.
In UMC, we use nicardipine.
Nicardipine?
Esmolol.
Esmolol?
Esmolol to control the blood pressure.
Nitroglycerin.
And we use the nitroglycerin.
Nitroglycerin, okay, great.
In the patient where hit the heart failure.
Yeah. Yeah, I think those are probably some of the most common that we use. How about at Cho Rai? What medicines are available and common?
We often use nitroglycerin and nicardipine.
Okay.
And maybe furosemide.
Okay. Excellent.
And captopril.
Captopril. Okay. There, a lot of the literature is suggesting medicines like clofidipine. I've never worked anywhere that has that. Matt or Shakira, do you guys have experience with clofidipine?
Yeah, Ryan, I was just going to bring that up. We actually are using it like almost exclusively now, which I think is a big change for us because I was always taught that you choose the agent based on the organ that you think is effective, like if it's the brain or the heart or whatever. But now actually our pharmacists are recommending it as first line for almost everything. And so we've started using it probably in the past year a lot more frequently.
Yeah. Yeah, I think clofidipine has a lot of advantages. It's very titratable, and as a calcium channel blocker, it has probably less contraindications. Well, you might be able to add to this because I'm covering most of just the most common medications. And so when you have somebody, and so now, remember, I'm going to go back up here. We're in this mode here. I should have put this back here, but we are right here. So we're in the general principles, not organ specific processes. So when we're just trying to control the blood pressure for hypertensive emergency, kind of the two most common medicines that we use here is single dose labetalol, which is a beta blocker. And you can give 10 to 20 milligrams IV. We don't use the beta blockers if we're suspecting acute heart failure. And then we'll commonly use nicardipine. If you have clofidipine, that's probably a better option, but nicardipine is also pretty good. There's some caution to avoid using this if you have acute cardiac ischemia, although I did not previously have that in my kind of mental model and practice pattern until I put this lecture together. So oftentimes what we'll do is if they have hypertensive emergency, I'll give them a first dose of labetalol. And if that doesn't seem to be controlled or it's bouncing back up, then I'll start them on nicardipine. If I think that this is pretty serious, I'll just put them on the nicardipine drip. The nicardipine usually mandates that's now a patient that needs to be admitted. So sometimes we try to manage them in a way that we might be able to send them home if we think that it's a somewhat reversible process. And so most of the other medications we'll use for kind of organ or disease specific processes. Anybody have anything to add to this? I mean, I know you were mentioning captopril, and we'll sometimes use like enalapril or some other ACE inhibitor for oral medications. But often if we've actually diagnosed them with a hypertensive emergency, we tend to lean towards parenteral or IV medications. Anybody have any thoughts or differences in their practice?
Hey, Ryan, I'll jump in. Oh, go ahead.
I'm sorry. I'm a Dr. Thảo in Charai Hospital. I think if we get a patient gets very high blood pressure, we need to take care. The second is what the organ is affected. If the patient gets pulmonary edema, I prefer to choose the glycerin tinnitus more than nicardipine. If the patient gets aortic dissection, I choose esmolol. And if the patient gets renal failures, I prefer nicardipine. Yeah.
Dr. Tao, I should incorporate you into my lecture because that's exactly the next things that we're going to talk about. And I 100% agree with you. So you should probably be giving this lecture instead of me, but those are excellent points. Shakira, you sounded like you also had something to say.
I am sorry. I was actually going to reiterate what you said, Ryan, was that I think I've changed my practice over the years because when patients come in now, in the first 10 minutes that I'm trying to figure out what's going on with them, I almost always go to labetalol if they're having symptoms until I figure out what drips we want to put them on. I'm not sure how difficult it is to get drips at UMC and Chorai, but I imagine it still takes a little bit of time to get the medication. And so I don't have another really great option that we can pull easily. So I love labetalol too.
Sounds good. And there's actually, I was really frustrated that I had to request the paper from the Eccles Library. And it's a paper that just came out in the last couple of years. And it basically asks the question, what do we do while we're waiting to figure out if this patient actually does have a hypertensive emergency or not? What are you supposed to do for treatment? And I think that's a really great question because we oftentimes, we say, find out if they have end organ damage. And while you're in the 1 or 2 or 3 hour process of figuring that out, what do you do? And I haven't gotten my hands on that paper. So I'm very curious to find out what people recommend. So just like Dr. Tao said, those are kind of general principles for hypertensive emergency, but what about the organ specific conditions? And there's kind of a handful. We're not going to talk about all of them, but let's talk about some of them. And so this is kind of the same pathway. Do they have elevated blood pressure? Do they have end organ damage? And how we identified or do we suspect an organ specific process? And if the answer is yes, then we want to focus on targeted principles, and we want to be a little bit more discerning in the medications and the interventions that we're implementing. So, of the organ-specific conditions, one interesting one is intracranial hemorrhage. Sometimes this is a subarachnoid hemorrhage. There's actually been recent guidelines that we want to get the systolic blood pressure. So remember, the general guidelines are lower the blood pressure by 25% in the first hour, right? And then kind of slow decrease since after that. For intracranial hemorrhage, there's kind of new guidelines that recommend systolic between 130 and 150. I had previously usually understood it to be 140 to 160. I think if you stay in the 140 range, you're probably safe. But you don't want to drop it down too low. You don't want to go below 130. The medications that they usually recommend are the nicardipine or the clofidipine if you have it. I've seen different practice patterns, but I've also been recommended by the neurosurgeons to avoid hydralazine. It can cause kind of a rebound tachycardia, and it's fairly unpredictable. And so they usually, the neurosurgeons that I work with don't like us to use hydralazine. And for any of these disease processes, if anybody has any kind of input or practice patterns or thoughts or cases they want to bring up, just feel free to chime in. And I'm just going to kind of work my way through here, but I would love to hear any thoughts or opinions because a lot of these are guidelines, but as we've already seen, even within the US, there's some difference between institutions and between what medicines you even have available to you. So just like Dr. Tao said, aortic dissection is a big one, right? And we kind of saw maybe this patient earlier. So there's kind of two goals with treating aortic dissection. We're going to want to decrease the shear force, and we on the aorta so that we're not making that dissection worse. And the way we do that is we lower both the rate and the blood pressure. We usually start by lowering the rate to less than 60 beats per minute. And that's done with esmolol. Esmolol is very short acting. It's a beta-1 blocker. And then if the blood pressure still remains high after that, oftentimes we'll add a second medication such as nicardipine, or if you have it, clofazimine. If you've identified acute coronary ischemia and like an MI, if you have a STEMI or they have like an NSTEMI, oftentimes, and I had never really done this before, is aggressively control the blood pressure, but the current recommendations are that you actually lower the systolic to 140, but you want to keep the diastolic above 60. So same thing, you don't want to drop them out. Here, since the nitroglycerin, we often use the abbreviation NTG. That's good at reducing both afterload and preload. So that's good on the work of the heart that's facing the ischemia. You can also use labetalol. There's some literature in there that suggests trying to avoid the calcium channel blockers, such as nicardipine in ischemia. But like I said, that I had not heard that before doing the research for this lecture. And as Dr. Tao expertly pointed out, when we're facing acute cardiogenic pulmonary edema, and there's a technicality on this slide that I feel obligated to bring up. I put lungs, but this is actually a heart problem, but I just already had a picture with a heart. So I'm putting the lungs because it's the most identified thing. But remember that this is a cardiogenic problem, just looks better with a different picture. And so our goal is decreasing that afterload and preload. And the goal is to get the systolic blood pressure down around 140. And we usually use nitroglycerin. Also, to improve the ventilation of all of that pulmonary edema, these are patients that respond really, really well to non-invasive positive pressure ventilation. That's the NIPPV or BiPAP. And I think we're all pretty familiar. I'm not going to go into detail on that. It's kind of a whole nother lecture on its own. For the nitroglycerin, I'm curious because in Detroit, we would be very aggressive giving relatively larger boluses of nitroglycerin. We would give 1 or 2 milligrams at a time. But in the institution that I'm at now, that is not common practice. And we'll usually start a drip at about 100 milligrams. And I was curious, when you guys start, like Dr. Tao, for example, you mentioned this, when if anybody knows kind of common dosing, what are people starting their nitroglycerin at? And are you giving bolus or are you just starting them on a drip?
In Vietnam, usually we just beginning with a low dose nitroglycerin, but in some case, in my practice and in a hospital, some doctor gets the bolus first. If the patient gets very high blood pressure, in some case, many cases, this has very have a brief effect. The patient have a good outcome, but in some case, the patient drop the blood pressure very quickly, but the ventilation not have good enough. So we need, in some case, the cardiac output much more works than the blood pressure. If we beginning with a nitroglycerin bolus, the patient drop blood pressure very quickly. Maybe make the patient more worse. Right. So in this case, we begin this with low dose.
Yeah, and that makes sense. And I think that I think is a more common practice.
Yes. And in UMCs, we use the nitroglycerin by drip or pump, and we use nitroglycerin based on the blood pressures. Maybe we lost furosemide, and we use the lift ventilations at the same time with the patient with the serious disease, serious acute pulmonary edema. we do the same times, nitroglycerin, furosemide, and lift ventilation.
Right.
We usually stock dose of nitroglycerin about 30 microgram per minute. But in some case with severe situation, we can increase the dose when we start about 30, or sorry, about 50, or even 100 or 150 microgram per minute. But we follow closely, carefully the patient blood pressure. After that, we load the nitroglycerin immediately. Yeah.
Okay. Yeah, and it sounds, and Matt is mentioning in the chat that they usually start at about 50 micrograms a minute and then kind of titrate upwards. An interesting thing about dosing, and I point this out to my residents. So we're all very used to giving sublingual nitro, right? And a sublingual nitro tab is 400 micrograms, right? It's 0.4 milligrams. The bioavailability of that is about 75%. So they're getting about 300 micrograms from that tablet. And for patients that come in with chest pain, for example, we'll often have like a kind of an automated order that it says, you know, give a tablet every 3 to 5 minutes until their chest pain goes away. And so if you imagine a person who's getting a sublingual nitro every 3 minutes, and if each time they're getting 300 micrograms into their system, you're functionally giving them 100 micrograms a minute. And we all feel very comfortable doing that with sublingual nitro, but sometimes when it's through the IV, it makes us nervous. So just, it's good to kind of reassure yourself if you're starting at a low dose nitroglycerin, like 20 or 30 micrograms a minute, it's good to reassure yourself that most often patients will tolerate a much higher dose than that. And you prove it by giving them sublingual nitro. And nitro is so short acting that sometimes when you start at the low doses, you kind of end up chasing your tail a little bit, and you have to, it's not until you really, really titrate up that you're making effect. So I don't want to encourage you to overdose your patients, but I think that in general, we oftentimes are underdosing our nitroglycerin. That being said, I learned my trade. I learned my practice in a place where people suffered from severe hypertension that was generally untreated for long periods of time.
Ryan, many years ago, about 50 years ago in Vietnam, we have many products about nitroglycerin for sublingual. But now we don't have any product about nitroglycerin for sublingual. We usually oral or IV drip, just only. But I know that some foreigner come to Ho Chi Minh City and sometimes visit our department. We usually add them what medicine they use every day. They usually sometimes they usually saw me some product about sublingual for nitroglycerin tablets or spray, tablets or spray. Yeah.
Yeah, it's a very common medicine here. It's actually part of our EMS, our ambulance system in California, in Fresno. They put the gel, they put the paste on the chest. I usually wipe it off. I don't like that because I don't know what dose they're getting, so I'd rather just administer it. But you know, interesting, you know, like sometimes there's also an interesting process that takes place within hypertensive emergency, and this is maybe a little bit outside of the scope of this, or maybe I should have included it, but you get the high pressure will cause the kidneys to produce a natriuresis. They will start to dump sodium, and that actually sometimes you end up with being hypo. You basically are volume down, so you're hypovolemic, because your kidneys are trying to adjust to that. And so a lot of times they will be in this cycle of kind of peripheral vasoconstriction that's creating this hypertensive emergency. And once you unmask that by decreasing the afterload with nitroglycerin, sometimes those are the patients that will drop their blood pressure. And it's actually because they're volume down, they're hypovolemic from that process itself. And they actually need even though their lungs are vascular, overloaded, and you would think, oh, that this patient is vascularly overloaded, they'll sometimes be hypovolemic. And you have to respond to that big drop in pressure with a relatively small bolus. So it's a little bit counterintuitive. These are great discussions, guys. I'm really enjoying this. I hope you are as well. This also, eclampsia and preeclampsia are also kind of a whole lecture onto themselves, but it's an example of a hypertensive emergency that's a disease-specific process. And the current goals are to lower the systolic blood pressure. The recommended medication is labetalol. And then always remember for these eclamptic patients, to prevent the seizures or to stop the seizures, that we're giving high dose magnesium. So 6 grams of magnesium. And then in patients that are having like an acute renal failure, and sometimes this is hard to know, you check a creatinine and it's elevated. Was it similar a month ago or a year ago? If you're lucky enough to have old labs, that can give you a sense. But if you do think that they're acute renal failure, if they have like hematuria or decreased urine output, then your goal is going to be back to that decreasing the systolic or the MAP by 25% in the first hour. The recommended medicine for this is phenoldiprem, which I have never had access to or used. Has anybody had any experience with this medicine?
Ryan, I've never heard that word before until just now.
Okay, so we can collectively, I think this is like a holdover of a medicine that's just not available. I wasn't sure if it was available in Vietnam, but I think going back to kind of your basics, your nicardipine are totally appropriate if you think the acute renal injury is due to it. So those are hypertensive emergencies. Now, what about hypertensive urgency? And we hear this all the time. I don't know if this is common in Vietnam, but in the US, this happens all the time. A patient went to their primary care doctor's office, so sent from their PMD. That's a abbreviation that we use, PMD, primary medical doctor. We sometimes say PCP, primary care provider. But they're sent from their PMD, no symptoms whatsoever, but they checked their blood pressure. It was 220 over 120. They said, oh my God, this is a hypertensive urgency. You need to go immediately to the emergency department. And they show up in the emergency department and they expect you to do something really big for them. Is that something that happens in Vietnam as well, or is that unique to the United States?
Yeah, every day we receive the patients like that. But when we check everything, some patients have a chronic kidney failure.
Yeah.
Sometimes just only 1 or 2 weeks later, the patient needs to kidney dialysis.
Dialysis, yeah.
Yeah.
Yeah, exactly. And so these can be tricky patients because we don't know what their underlying disease process is. But this term hypertensive urgency is somewhat like the Loch Ness Monster, something that basically does not exist. And I think we are in the process of getting rid of this term from the lexicon of emergency medicine. There's a holdover in a lot of the other specialties, but for our purposes, it doesn't really exist. And I asked Dai, and he said that you may or may not know the Loch Ness Monster, but you might know this, the search for Onke. Am I pronouncing it right? Dai, how do we pronounce it? Onke.
Onke, great.
Onke.
Yeah, Onke.
So hypertensive.
You can get a Vietnamese certificate.
Yes, usually whenever I try to say something, people just tell me to stop talking. But yeah, onke. So this is hypertensive urgency is like onke. It's an imaginary entity. Back in 2013, ACEP, which is the American College of Emergency Physicians, their recommendations were if patient shows up with asymptomatic elevated blood pressure, that a workup is not necessarily required. It's not required. You can, if you suspect that this is someone who has not been getting good regular care, you suspect they haven't had labs done in a while, and you want to just kind of perform basic screening on them, you can, but it's certainly not required. They also said that medical intervention is not required. So you can actually just discharge that patient. You don't have to give them medicines and wait till their blood pressure improves to any certain number. And there's actually some literature that suggests that doing so is actually harmful, and you can actually cause harm by trying to be overly aggressive in controlling their blood pressure. So this is always a challenge because they show up from their doctor and they expect something to be done. But kind of like Dr. Howe mentioned, sometimes it's appropriate to do a basic screening exam and it, you know, on your patients. You know, where I work now, patients have very poor access to primary care, and sometimes we draw labs because they're not going to get it done anywhere else. You know, when we were in Utah or some other places that I've worked where patients have maybe better access to primary care, maybe such an aggressive intervention or screening is not as necessary. So I think we need to just try to erase that concept from your brain altogether. That there is something as such as hypertensive urgency. There's elevated blood pressure and there is hypertensive emergency. Those are two separate processes, and there's no kind of hypertensive urgency. And if we catch you guys treating hypertensive urgency in the emergency department, onke is going to get you. It's going to take you away in the middle of the night. So kind of a basic review of what we've talked about. The patient comes in, do they have an elevated blood pressure? If they don't have an elevated blood pressure, as far as hypertensive emergency, by definition, you're fine. If they do have an elevated blood pressure, look for end organ damage. Do a very complete history and exam. Try to find out. They may not realize that they haven't peed for 2 days, right? Or they may not realize that their arm is weak. And so get a good history, get a really good physical exam. And if you have a suspicion, a specific suspicion, do those tests. You know, did they show up with the, you know, new onset neurologic findings? Do they have chest pain that's a tearing chest pain that's ripping into their back and warrants a workup? But if you have not identified end organ damage, again, you're good. You're all cool. You don't need to worry too much about this. This is potentially a hypertensive urgency. Do your screening as you would otherwise, but you don't need to employ any heroic interventions. And then have you identified an organ-specific process? Because we have elevated blood pressure, we have end organ damage. If there is no organ-specific process, apply your general principles. Give them some labetalol, give them nicardipine, lower that blood pressure by 25% in the first hour. And if you do identify organ-specific process, oh, this patient is pregnant, I'm worried about eclampsia, or some other example, then use your targeted principles. And there's a few more principles that we didn't talk about, but just kind of be aware of them. And it's good to kind of keep those ready because you kind of want to act quickly on those specific processes. I've never done an actual quiz with this, but I'm going to try because I just threw a few of these things together. Do you guys want to try doing a little quiz? I don't know what time is it. How are we doing for time? I can't see my screen.
You're good. You've got like 8 more minutes.
8 more minutes. We'll do it. I've made an 8-minute quiz, luckily enough. let's see here. Let's stop sharing.
Hey, Ryan.
Yeah.
Can I just ask a quick question?
Totally.
How, like, in what scenario are you applying the general treatment? Like, in what patient are you doing that? Like, if the patient's like, yeah, I have high blood pressure, but I don't, have unilateral weakness. I'm peeing okay. My right upper quadrant doesn't hurt. You're obviously not going to do anything for them. So I guess my question is, like, usually they have some sort of complaint that you're suspicious of, and that's why you're going to do the labs, and so you'll treat them in that, organ system.
Right. And so, yeah, Shania's question, you guys, is a good one. How, who falls out of that organ specific process? So I think if you find somebody and they are either encephalopathic, or maybe they have some neuro deficits that you haven't identified an acute process on head imaging. If they, if you've identified new like retinopathies or increased ICP from doing the optic nerve ultrasound, if you identify them with new onset renal failure. The chest pain one is a challenge because there's differing opinions whether ongoing chest pain in the setting of a hypertensive emergency or acute hypertension qualifies as hypertensive emergency or not. But those are people that I would usually kind of target that 25% decrease on. And sometimes there's people that they have acute symptoms that you haven't really pinned your diagnoses on in general, or you're kind of in the process of working them up. And I'll kind of target that first goal of 25% in that initial workup period. And depending on where you work, that initial workup period can be quite long. So for example, in our institution, even though it's the third busiest hospital in the emergency department in California, it often takes 5 or 6 hours to get a CT scan, even emergently. So in patients where it's undifferentiated and I feel like it's going to be a little while, like maybe they have bad chest pain, I'm worried about an aortic dissection, but I know it's going to be 6 hours, then I'll kind of try to apply those general principles. But it's a really good question. All right. Let's see. Can you guys see the poll?
No.
Oh, wait, launch. Here we go. Let's launch the poll.